Hello everyone and welcome back to the channel. Today I am presenting a rare and important case of Ortner's syndrome, also known as cardiovocal syndrome, where a chronic dry cough turned out to be the warning sign of a life-threatening thoracic aortic dissection. Ortner's syndrome classically presents with hoarseness of voice caused by recurrent laryngeal nerve compression secondary to cardiovascular disease. However, patients may also present with chronic cough, dysphagia, dysphonia, wheezing, or stridor. Our patient was a 60-year-old male with hypertension and dyslipidemia who had been experiencing a persistent dry cough for more than 9 months. He was a non-smoker. Initially, his cough was thought to be related to lisinopril use, so the medication was discontinued. Despite this, the cough persisted. He later presented to the ER after an episode of syncope associated with seizure-like activity. On arrival, his blood pressure was stable at 118/72, heart rate was 113 beats per minute, and oxygen saturation was 94% on room air. Although responsive to verbal commands, he remained obtunded. Initial cardiopulmonary examination was unremarkable. EKG showed normal sinus rhythm without ischemic changes. Chest X-ray revealed cardiomegaly. CT angiogram of the head and neck was negative for acute intracranial pathology but demonstrated edema throughout the upper mediastinum. Shortly afterward, the patient rapidly deteriorated. He became hypotensive despite aggressive fluid resuscitation and required norepinephrine support. He subsequently developed acute anuric renal failure with a marked rise in creatinine, along with worsening liver function test suggestive of ischemic hepatitis. Beside echocardiography revealed a large anterior pericardial effusion concerning for cardiac tamponade. Once stabilized, CT imaging of the chest, abdomen, and pelvis demonstrated a 5 cm ascending thoracic aortic aneurysm with suspected aortic dissection and moderate pericardial effusion. The patient was transferred emergently to the tertiary center for definitive surgical management. This case is remarkable because chronic cough was the patient's primary symptoms for several months. In Ortner's syndrome, enlargement of cardiovascular structure can compress the recurrent laryngeal nerve as it loops around the aortic arch, producing cough or vocal symptoms. Another important point is that aortic dissection does not always present with classic tearing chest pain. Neurological symptoms such as syncopal episodes, altered mental status, or seizure-like activity may occur and can delay the diagnosis. Our patient also developed malperfusion syndrome with multi-organ ischemia involving the kidneys, livers, which significantly increases mortality. This case highlights the importance of maintaining a broad differential diagnosis when evaluating a persistent, unexplained cough, especially in patients with cardiovascular risk factor. Thank you for watching. If you found this case educational, please like, subscribe, and share. See you in the next presentation.